right, good afternoon, or I guess good morning or good evening, depending upon where you're joining us from today. On behalf of Axiom, a very warm welcome and special thank you to our expert panelists. For today's town hall, I think we're kind of trying to keep in line with Axiom's core mission as a think tank. It's really thinking about how do we bridge some of those critical knowledge gaps, whether that be from the healthcare community, our academic leaders, the biopharma industry, but kind of always keeping that patient-centric voice at heart. During today's topic, we'll really be delving into the world of oncology and thinking about some of these new trends that we're starting to see, be that data coming out of the most recent Congress at ESMO, or how are new therapies being developed and brought forward, be that in a single tumor fashion or a pan-tumor fashion. With that, I will pass it off to my colleague, Max, who will take us through the flow for today.
Thanks, John. Nice to see everyone. My name is Max. I'm an engagement lead at Axiom, and really delighted to be able to have this discussion today with such a strong panel. So I think all of us who are here in the oncology space are trying to sort of make sense of this evolving paradigm where we're all used to thinking about dividing up patients by tumor and then going a level down into patient biomarker status and so on. But we're starting to see that sort of paradigm break down a little bit. So I'm excited to have this group here to help us really make sense of all this, help us understand, to the best that we can, what the future is going to look like with all of these pan-tumor targets emerging. And, excited to jump into the conversation. So we'll have each of our guests do an intro here in just a second. First, I want to just say quickly to everyone who's watching, thank you for joining us. Please feel free to drop questions into the chat. We'll do our best to monitor those. And if there's an opportunity to squeeze those in, we'll certainly try to do that. So with that out of the way, we'll jump right into intros. We'll start with Dr. LaRusso, then Dr. Burdness, and then Dr. Schrum.
Hi, everyone. Thank you for joining us today, be it whatever time zone you're in. I'm Pat LaRusso. I'm a medical oncologist. I practice at Yale University, Yale Cancer Center. I run their early phase clinical trials program there.
Hi, everybody. Thank you for being here. I'm Barbara Burdness. I'm also a medical oncologist at Yale. My focus is on head and neck cancer, and I'm the Associate Director for Translational Science at Yale.
Hi, everyone. My name is Allison Schramm. I'm a medical oncologist at Memorial Sloan Kettering Cancer Center. My focus is early drug development in solid tumors, and I have a particular interest in gynecologic cancers.
Perfect. Excellent. Thank you again so much for all of you being here. I want to jump right into the deep questions and start with this sort of hyper zoomed out view and get a bit of a temperature check from each of you on where you stand broadly on this topic, because obviously there are limitations to, the pan-tumor approach. We know, of course, also that not all targets are expressed across most tumors, but we're clearly identifying more and more of these, so-called pan-tumor targets, right? Just at ESMO, we've seen Claudin 18.2s, we've seen HER3, KRAS G12Cs, TROP2s, a lot of developments. So just to get a sense of how optimistic each of you are with respect to this development, here's the question. In the next 5 years, do you see pan-tumor development becoming a major pillar alongside tumor-specific programs, or do you think this is going to remain more of a sort of specialized tool that's used only in very niche cases? We'll start with Dr. Burdness.
So I think actually somewhere in between. I think we're going to see way more pan-tumor approvals than we've had in the past. But I think we're going to continue to see that, and maybe more particularly for targeted therapies that are after signaling molecules, after oncogenic drivers. I think there's still going to be many of these agents where even if you have the right mutation, the disease context is going to be very important. Likewise for ADCs, we're moving to the belief that you don't really need that much of the target, but what's co-expressed might be important in terms of internalization, and susceptibility to the payload may differ by tumor type. So I think the pan-tumor is going to be increasingly important, but I think there are still going to be many times when it doesn't translate to everything. And then I'll just say one other thing. I work in a somewhat less common cancer where drug development is always a little bit slower. So we love, these basket trials where there's an opportunity to get a signal in our disease early.
And it's really interesting to get it for a second. It's such a great point on the co-expression. I'm curious, Dr. LaRusso, I know you spend a good amount of time in the early stage and looking at early development. So you must see a lot of sort of the new targets and things coming out. I'm curious from your perspective, how optimistic are you? How likely are we going to see this sort of start to become a major pillar in the next 5 years?
I mean, I think it is going to become a major pillar, but I think, as Barbara said, there are certain components of this that we need to keep in mind. So right now, there are a lot of drugs moving forward with a lot of different targets. Let's just look at ADCs as an example. A lot of different targets, similar payloads. They may be analogs of Topo1 as an example, but they're for the most part similar. And even though we may see a pan-tumor effect, I honestly think that what we also need to identify and focus on as well is biomarker or target development. Biomarker development relative to the targets and understanding the biology better, because many times sequencing of these drugs is not necessarily going to be beneficial if, for instance, with payloads, with ADCs, if the payload is similar. So even though, as an example, Enhertu, you can see it active in many different tumor types, or even looking specifically at breast cancer, HER2 negative versus HER2 3+, the variability of efficacy is somewhat the duration of efficacy is somewhat different. And so as we're developing these pan-tumor drugs, we also want to keep in mind that we want to give the best drug to the patient as early as possible to give them the best therapeutic advantage, especially if there are similar therapeutic benefits, but toxicity differentials can be profound.
That's a really helpful perspective. Oh, sorry, go ahead, John.
No, it's fine. And this is a tangential question, Dr. LaRusso, because I think you brought it up a little bit here and using kind of ADCs as the example, right? Because Dr. Burton, as you mentioned, or I forget which one of you, but like it's less so the target, at least when it comes to ADCs, but maybe it's the linker and payload component. From a sequencing perspective, at least maybe what you're starting to see, is there a world where we start sequencing ADCs and that's where different payloads or linker technology is needed? Like, just curious, any top line perspectives that the group might have.
Yeah, I mean, I think Barbara and Allie can probably chime in here probably better than I can, but don't underestimate the power of each of the three components. So yeah, TROP2, we're not really looking for a biomarker or a target, and we're giving these drugs, without predefining within the tumor a specific target. But I'm not yet 100% convinced that we don't need to develop more selective targets, especially given the mass number of ADCs. There's over 500 of them that are in the clinic currently. Over 100 that have just 120 or 30 that have gone in 2025. So although you might have a drug like SASI that may be active in multiple different tumors without ever looking for a biomarker or quantitating it, I think that is why many companies now are starting to develop much more sophisticated biomarker and quantification development, because we recognize that we need to take into consideration and develop simultaneously tools that are going to help us define the best monoclonal, potentially better linkers, and obviously different payloads. I mean, Allie, what do you think?
Yeah, no, I completely agree with everything that has been said thus far. I think it is very clear that we will need a diversification of payloads, as Pat said. But we all also, really all three components are critical. If you have an ADC where the payload isn't released, and we've seen that, the drug's not going to have efficacy. If you have a payload where it's being released readily into the circulation, there's a toxicity problem. So you need both, you need all of the three components to really be optimized in order to develop a best-in-class drug. And all of the, there's the 500 plus ADCs that are in development. I do wonder, once you have one or two topo 1 ADCs for a particular indication, what's going to happen to the rest of them that are being developed in that space? And there is going to be some overlapping resistance that occurs if you have the same payload, if you have the same target. It may not be complete cross resistance. They're both probably important, but I think really further developing the biomarker, optimizing the linker technology, and then diversification of the payload are three really critical aspects.
And I can take that one step farther. Allie is a GYN oncologist, so she knows a lot about folate receptor alpha. So if we look at some of the data that was presented at ESMO and ASCO in the last few months, there were several folate receptor alpha targeted ADCs that were presented that specifically had topo 1 payloads. In the past, we thought topo 1 payload, no ophthalmologic toxicity. We're seeing that though with the AZ drug. We also are seeing, at least albeit very preliminary in phase 1, that with the same monoclonal antibody and the same linker, just changing the chemistry of the payload slightly can significantly improve upon the efficacy. So we still have a long way to go as we're developing the ADC portfolio.
Can I go back to something that Pat said, I think, two times ago? And that is the question of sequencing. And so I think we're thinking about sequencing a lot in terms of the payload. I would argue that we also need to think about it in terms of the target. So, huge excitement when we recognize that ADCs can work even with a pretty low amount of antigen present. But I think we all think that they work better if there's a ton, right? And I've been involved in head and neck cancer, where EGFR is extremely richly expressed, but resistance can be driven by HER2 and HER3. And, the question has been, well, what's enough HER2 or HER3 then that you'd be interested in Enhertu or patritumab deruxtecan? But it may be that the internalization characteristics of those drugs are different when you have a million EGFR receptors around that are heterodimerizing with them. And so it may be important to understand how you can co-target the more prevalent and the less prevalent antigen. I think we also are aware in a lot of the epithelial cancers about EMT and antigen loss, right? And so Pat raised the question, you want to use the best drug the earliest. But for a lot of these targets, not necessarily all of them, some of them might be EMT targets, but for a lot of these targets, earlier is going to be better because your other therapies aren't going to have led to antigen loss. So I think that the pan-tumor is incredibly powerful for bringing these agents forward, showing signals, letting those of us who do less common cancers play in the sandbox also. But I think there is going to be a level at which understanding the biology, not only at the disease level, but at the patient level, is going to be important to optimize the use, particularly of ADCs.
And one other biology that I'd like to add to that, the biology of the drug. There's three components to the biology of, I think, how we're going to be able to develop drugs or administer drugs in the future. Biology of the drug, biology of the tumor, biology of the patient.
And I think you made a great point earlier, kind of getting back to the pan-tumor question of we need better sort of tools and sort of screening to get to that. And I want to ask Dr. Schrum, as you're listening to this, we know that you were involved in the ESMO working group development of the ETAC-S tool, the ESMO tumor-agnostic classifier and screener tool. So can you tell us a little bit more about that and how you sort of envision that being used by oncologists across tumors?
Yes. So thank you for asking the question. I think, one of the most common questions that I get is, what is the bar for a tumor agnostic approval, or what do you consider to be tumor agnostic versus tumor specific or restricted? And so in order to help get some kind of tangible benchmarks, we looked at the FDA approvals that were tumor agnostic thus far and tried to understand how many tumor types are being looked at in these trials. Of those tumor types, how many showed impressive efficacy? Did there need to be a minimum number of patients per tumor type? What was the overall response rate? And then what was the durability of those responses? And trying to really get a handle on what makes a tumor agnostic drug. As Barbara mentioned before, which I think is a really good point. It truly is not dichotomous in terms of it's tumor agnostic and it works in all patients and all tumor types, or it works in one specific demographic. There really is more of a continuum. But practically speaking, when it comes to getting drugs approved, we need to be able to make these decisions. So, we looked at the current approvals and made some guidelines in terms of what the overall response rate should be, what the durability should be, generally speaking. And in general, I would say, what came out from that classifier is that you need to explore multiple different cancer types. You need there to be appreciable efficacy. The response rates have generally been 30% or more. The pembrolizumab approval for TMB high was a little bit unique in that the bar for overall response rate was lower there, but that's because the durability was extremely long. And so taking each of these things together to really understand, but the classifier essentially says that you need several different tumor types with overall response rates that are above these bars, 30% or higher, generally speaking. And the denominators for those tumor types need to be sufficiently large, and there needs to be durability of the responses. And so it's just a way to kind of benchmark. And that is the classifier is not meant to say if you meet these guidelines, then you have a tumor agnostic drug or there should be a tumor agnostic approval. It really is meant to be used as, this could be, you should further explore it. And it's, I would say, kind of a reality check. Do I have a drug that even has the potential for this indication? But there will sometimes be these exceptions. And so it's important to note that even for drugs that we think of are, quote unquote, tumor agnostic, there may be one disease type or two disease types that don't seem to really be as responsive. And so we've seen that, for example, in the dabrafenib trametinib FDA approval, where colorectal cancer was clearly not responding as well to that combination as other cancer types were. And so there was an FDA approval that excluded that specific cancer type, but was otherwise tumor agnostic, I would say. And you do see that biology matters, even when it comes to these quote unquote tumor agnostic targets and drugs. And so as we look forward, I think it's important to look at, are you exploring multiple different cancer types? Are there responses in multiple different cancer types with sufficient numbers in each of those tumor types? But look also at the durability and then understand, are there exceptions to the rule that would be helpful to know? Because at the end of the day, when you see a patient in your clinic, you want to know, is this the right drug for this person?
Yeah, I think it's such an interesting question you point out of, when a target might work or a drug might work in certain tumors and not others. And I think this leads to, some interesting questions. And if you'll allow me to kind of nerd out a little bit for those of us who are interested in getting into the science here behind the pan-tumor targets. And one of the questions from my perspective, I think people in this space are trying to better understand is the question of, the target biology versus how that target may behave differently across various tumors. Right. So to make that more concrete, right, we saw ESMO, for example, the MK1084, we saw somewhere between 35 to 40% ORR across multiple KRAS G12C tumors. So when you see something like that, how much of that would you say is attributable to the biology of the target itself versus maybe the homogeneity of how that target behaves and is expressed across various tumors? Or is it both, or is it neither? Am I totally missing something? I'm curious, what folks think about this. And maybe since we're just talking, Dr. Shram, if you have a take on this, and I would love to hear also from our other panelists.
Yeah, no, I think that's really the major question. And I think the short answer is it's all of it, right? It's both. What KRAS G12C does and how it drives cancer is different depending on the histology, the context. Is there also EGFR that's highly expressed in that cancer type? Is there EGFR that's highly expressed in that particular patient? Even within a cancer type, there is a different co-mutational profile with each patient and different differential expression. Perhaps there is EMT. So I think that there's the biology is different from histology to histology in some capacity, and even within histologies, the biology is different. But I think taking a step back, if you look at the tumor-agnostic approvals to date, it's interesting that they have been very different. So there's the straightforward, you have a BRAF V600E mutation, we're going to give an inhibitor of this particular pathway. But then you also have, for example, TDXD for HER2 overexpressing cancers, which is not looking at targeting a driver alteration and stopping oncogenic signaling. It's looking at it's an ADC. It's effectively chemotherapy in a targeted way, and the biomarker is very different. So how that correlates from histology to histology is different than an oncogenic driver with a specific mutation. And that's even further different than, for example, the pembrolizumab and the dostarlimab approvals for microsatellite instability or TMB high. These biomarkers are inherently not just different in what they are, but how they are biomarkers. And the drugs work differently in these different situations, so that the shared process is that they are effective in an appreciable number of patients, regardless of what cancer type they're found on. But the biology of the biomarkers and the drugs used to target those biomarkers are very different from approval to approval.
If I could
I'm sorry, Barb, please go.
Sorry. Just to play out the KRAS thing a little bit, though. I think one of the reasons that KRAS is appealing for pan-tumor approvals is that it's generally a driver when it's mutated. So this is picking up on what Ali was saying, but you could look at the phospho-AKT or the PI3 kinase inhibitors as the contra example, right? Where there's huge differences in how active they are across tumors, because you may have mutations in PI3 kinase without it really being the driver event in a given cancer, right? So I think that comes back to again, that it's not enough to know the target, that you really have to position it within its biology.
Yeah, I mean, in the metastatic setting, that is, it's proven itself over and over again. Just looking at, G12C inhibitors or even one specific and different tumor types, you can get, a much better response in one tumor type than a different tumor type. But within the histologies, that only 25 or 30% of the patients are going to respond, because you have other alterations. You have differences in the tumor microenvironment, even within the same histologic tumor type. You have differences in epigenetic pathways. And so the biology is so complex that even though you might consider an agnostic approach, that's where we really have to understand what's going on. When these patients progress that have responded, if you look at them, no two patients' tumors have the same, profile at progression, which tells you just how complicated hitting only one driver is.
Yeah, and I think I completely agree. And I will say, as a gynecologic medical oncologist, low-grade serous ovarian cancer is an interesting example. It's a rare tumor type, but it frequently has MAP kinase alterations, including KRAS mutations, and MEK inhibitor monotherapy is actually pretty effective in low-grade serous ovarian cancer. But if you look at KRAS mutations across the board at lung cancer, pancreatic cancer, colorectal cancer, you're not going to get very far with a MEK inhibitor. So despite it being the same KRAS mutation, it's KRAS G12, D or often V, but nonetheless, the histology does matter despite KRAS still being the driver. And so I think the histology clearly matters, but also the actual drug matters. So if you look, for example, at HER2 ADCs, TDM1 came before T-DXd, and maybe we would have thought that HER2 low or HER2 intermediate expressing was not a sufficient biomarker for HER2 ADC. And then when T-DXd came around, we said, well, actually, maybe you don't need extreme levels of HER2 for there to be an effectively targeted strategy for HER2. And so all of these things matter, right? The histology matters, the drug itself matters. So I don't think it's just one thing.
Is there a world where, because you're talking about being able to hit a tumor from multiple angles, right? Where maybe some of these multi-specifics or even tri-specifics that are being developed could theoretically have greater potential in a pan-tumor setting, being able to kind of target the tumor from multiple angles?
Well, I think that's currently under exploration. I mean, we saw the PD-1 VEGF data, the readout from the phase 3 in China. Now, we haven't yet seen that same readout here, in the Summit initial readout of their randomized phase 3 was, I would say, conservatively not as exciting as that. But if you look at the readout of the randomized phase 3 from the study that was presented that was positive, I mean, yeah, giving this one drug that has PD-1 VEGF in combination with chemotherapy seemed to be better than just PD-1. I know there's VEGF involved as well, but many people, I mean, that's why we're developing biparatopics, bispecifics, because many people feel that if you can target better two different targets, you might be able to get better efficacy within one drug than if you try to maximize efficacy within two drugs based on toxicity overlap, based on financial toxicity, et cetera. But one of the things many people are now starting to think about is the geography, the geographical distance between those targets. Or is one target going after the TME, whereas the other target is actually going after a receptor within the tumor cell? Very complicated, very exciting, but really is trying to hone in on biology and therapeutic advances based on tumor biology.
I would say there are also some combinations where we're not thinking so much about, okay, these are the two most important targets when we start, but where the mechanism of resistance is so well defined. And so I think, amivantamab would be a great example of understanding that MET gets upregulated the more successfully you target EGFR. Or some of the studies that are opening now in the combo match, where you're looking at targeting something and then co-targeting the adaptive resistance pathway. So I think the concept of a bispecific or a combination that is trying to maximally inhibit the important targets in a cancer is really important. But then increasingly we understand that the better you are at targeting something, the more rapidly you're going to have to understand what the resistance pathways are.
Yeah, and Dr. Burtress, I'm curious because I think a lot of this begs the question, right, from a practical standpoint, right? And a lot of the people that we have sort of listening today may be folks who are either within pharma or biotech and are trying to figure out what all this means sort of from the perspective of designing their pan-tumor trials, or even if they should be pursuing pan-tumor approaches, as we've talked about. So I guess as someone who's, admittedly in a space where the development is quite slow and can benefit a lot from these pan-tumor approaches, what advice, I guess, would you have for those who are at that pivot point in terms of how to think about designing those pan-tumor development strategies, whether it be a basket trial or something else?
Well, I think you've already heard from my co-panelists some really important things. One is start developing your biomarker, start understanding your patient population from very early on. So you think you have a target that's important across a range of cancers and you're starting a basket trial. I think that's a great way to find a signal, but don't wait till you're all done with that to start then asking, what was the level of target expression? What were potential mechanisms of resistance going on here?
And remember and I think Allie and Barb would agree, there's a difference between pan-tumor versus multi-tumor trial. We're seeing less and less pan-tumor trials in early phase, because if the biology doesn't lend itself to treating a tumor because that target doesn't exist, or that mechanism is not as meaningful in specific tumors over others, then we have multi-tumor trials, maybe 4 tumor types, maybe 6 tumor types, 3 tumor types, whatever. But then if there's tumors that you're really, really wanting to hone in on, you bring those patients, you allow for multi-tumor escalation, but you bring those two specific tumor types into backfill cohorts so that you can hopefully get a greater denominator of patients to investigate. But also that's where you're probably going to be able to get the greatest number of biopsies if you really want to understand whether or not the drug is doing what it's supposed to do within the tumor. So we're seeing a lot of those. They're very, very common trials these days. Allie, I don't know.
Yeah, no, I would completely agree. I think, a couple of things to add here, really extrapolating on what you just said. But one is, I'm increasingly seeing a design where, for example, if a biomarker seems to be enriched in one histology but is present in others, you can have these co-primary endpoints where, the primary endpoint is the overall response rate in ovarian cancer, and the secondary analysis looks at the overall population, including all patients. And so that's a way of potentially pursuing both questions at the same time. If your hypothesis is that this may have tumor-agnostic or multi-tumor potential, but you're most likely to see activity in a certain disease type, you actually can explore those things simultaneously in a single trial where you're powering the study to enroll more patients with a specific disease, and that might even be registrational. So I do think that it's possible to do both things at the same time. And I like Barbara, have a fondness for basket trials in large part because I treat rare diseases oftentimes. And so I think basket trials have a couple of different potential goals. One, of course, is, yes, a tumor-agnostic FDA approval or a regulatory approval that leads to the drug being available to anyone with that biomarker. That is obviously a very aspirational goal for many of these drugs. But I think another utility of basket trials is more exploratory, and that's really just understanding in these rare tumor types that you might not be able to enroll an entire trial, is there activity, and is that worth investing additional resources to try and find these patients and make larger cohorts or individual phase 2s looking at that specific indication. And there are often, a basket trial might be quote unquote negative because you didn't get an FDA approval in a pan-cancer way, but you see these signals of extreme activity in these rare tumor types. And for a patient that has one of those rare tumor types, that's very meaningful. And an example I would give is, I ran a basket, or among others, was leading a basket trial of a combination of a PARP inhibitor and immunotherapy. There were several similar basket trials looking for patients with, BRCA altered cancer types. And the overall trial, I would say, was largely negative in that the patients that seemed to benefit for the most part were those that we knew might benefit: breast cancer, prostate cancer, pancreatic cancer, and ovarian cancer. However, there were 3 patients with this rare uterine sarcoma, uterine leiomyosarcoma, and those were the 3 best responders on the entire trial, who have a disease that has, an overall survival of typically 6 months or so. And these 3 patients had either partial or complete responses that lasted years. And so that actually led not to an FDA approval because it's a rare indication and hard to enroll a whole trial, but there's an NCCN listing now for PARP inhibitors in that patient population. And, larger retrospective studies have really validated the efficacy of PARP inhibitors in that rare histology. And so I think basket trials can be a useful tool to really get signals in terms of where is my drug active. Maybe a rare indication, maybe not. Maybe it's a common indication, but just not all of the common indications. And then, of course, it would be great if the drug was effective across the board, in which case you might get an agnostic approval.
Yeah, I think it's such a great point you touch on, right, from the patient perspective. Obviously, those patients who are in those more rare tumor types are going to be the ones who benefit the most from these types of developments. But I'm curious, beyond sort of the benefits of, improved, efficiency and sort of that piece of it, do you see sort of any practical changes in how, patients are going to be affected as we move to these more, pan-tumor or multi-tumor approaches? Like, is there going to be any meaningful changes from the way that patients are going to seek care from that perspective, or do you see it sort of more just from a development standpoint?
It's a tough one to answer.
I will say, I think for the foreseeable future, and if I understand your question correctly,
Yes.
I think for the foreseeable future, patients are still going to be largely going to doctors who specialize in their tumor type. Of course, the most of the country is seeing a medical oncologist who has not just an extreme specialty, but sees all cancer types, right? So community oncologists see patients regardless of where the cancer type is. And so that will be a point person that has, fortunately, knowledge of how to treat all different cancer types. But in terms of at the more specialized centers where you have a breast cancer oncologist or a GI oncologist or a GU oncologist, I think that model will remain for the foreseeable future, but there will be increasing crosstalk between the disease types, educational opportunities where the conference is not a GI conference, but it's a KRAS conference, or, so I do think that there's going to be more collaboration going forward. And if you see a GI oncologist, but there's a breast cancer oncologist who has an expertise in a particular molecular biomarker, there will be more talk between those groups. But I don't think that the whole paradigm for being treated based on your disease is going to change in the foreseeable future. And I think another kind of peripherally related comment to that is that these basket trials, the endpoint here is often the overall response, right, and the duration of response. But it's really hard to make meaningful conclusions about, for example, progression-free survival or overall survival when you have such a heterogeneous group of patients.
And 20 patients per cohort.
Right, exactly. So if you can't, and you can't randomize, right? Because you can't randomize a basket cohort to docetaxel because docetaxel is not effective in all cancer types and is not considered standard of care. And you can't randomize to standard of care. You can try, but the standard of care differs substantially from disease type to disease type, and how effective the standard of care is differs. So I think there are clear limitations to a basket trial in terms of really understanding from how it compares. And so histology-specific trials will still be very important, and seeing a histology-specific expert, or at least understanding the paradigm for your tumor type, is still going to be very important going forward.
If I could just make a comment about doing the histology-specific clinical trials, that you are managing the patient in terms of their drug and their drug toxicity, but you're also managing them in terms of their cancer. And that might have different implications in terms of late effects of their prior definitive therapy, or it might have different implications in terms of where the metastases are. But we see clear indications that the competence, that's the wrong word, but the expertise with which that care is delivered can affect the results of phase 3 trials. And in particular, we've often seen in head and neck cancer trials that there's a different survival for patients who are accrued in Eastern Europe than in some of the other areas that have contributed to these trials. And that is likely related to the lack of disease-specific expertise around bleeding complications, aspiration, other things like that. So I think in order to answer the questions that Allie raised about PFS and OS, and in order to answer the questions about where does this fit into your multidisciplinary paradigm and where does this fit into the sequence of other therapies that are available for that disease, you want those studies done by people who know how to manage that cancer.
The drugs may be quote unquote agnostic, but the diseases are anything but agnostic. Not only in terms of therapeutic benefit from specific drugs, but presentation, comorbidities just of the disease themselves what Allie sees as major comorbidities in ovarian cancer, as an example, are totally different than what Barbara sees as comorbidities in head and neck cancer and I see in breast cancer. Having the expertise behind you to treat the tumor-related comorbidities can actually help also with therapeutic outcome. And may need to be incorporated somewhat into trial design or how you're thinking about trial design.
Yeah, and absolutely agree with that. And I think even the toxicity that a drug has might actually differ based on your tumor type. So a patient with pancreatic cancer might have baseline diarrhea from enzyme insufficiency, or they may have diabetes as a consequence of their cancer, and so they may not tolerate a drug that causes significant diarrhea, and that is different than in endometrial cancer, for example. Often there's insulin resistance, and so that is perhaps different than a breast cancer population. And so you do actually see that the toxicity from the same drug at the same dose can differ by histology. And we have several examples where different doses have been approved in different diseases based on the trials that show that the tolerability is actually different from one tumor type to another. In endometrial cancer, lenvatinib is used. It's also used in many different diseases, and the dose that is used and the tolerability really does differ depending on the patient population, as an example.
And I think the interesting thing is, as we're discussing, as I'm listening to people talk, like, yes, we're moving towards this pan-tumor, multi-tumor environment, but we are still a long ways away, and there's still a lot of variability between each of the tumors types and where we are in terms of development. So I think, we haven't answered all the questions. I don't think we've solved the pan-tumor question yet. But I am really curious. We like to do this at the end of our sort of ESMO town halls, is to just get a sense from each of you, from your specific expertise areas. What is it that you're excited for coming up? What is the exciting data you've seen at ESMO, and how you sort of view, the next couple of years in terms of what's on the horizon. So sort of a broad question and what you're optimistic about. And for this last round, we will start with Dr. Burness, please.
So we had some disappointing presentations in head and neck at ESMO. The CD47 phase 3 trials were negative. But we saw from Origami 4, which is a trial of amivantamab in head and neck cancer, the first presentation. So it's a big 6-cohort study looking at different combinations with chemo and pembro and neoadjuvant and whatnot. But so the first cohort, which was treatment refractory disease, was presented with a response rate in the mid 40% range. And that is moving forward to a first line phase 3 study, which is going to be pembrolizumab chemotherapy versus pembrolizumab, amivantamab, and carboplatin. So I think we're excited about that. It comes a little bit behind 2 other phase 3s of bispecifics. So petosemtamab and ficerafusp are also out there. But we think adding some form of EGFR targeting bispecific to immunotherapy is very likely to emerge as a winner over the next couple of years. The other thing that we saw was a trial from China with another PD-1 inhibitor in combination with chemotherapy in the neoadjuvant setting. So people may know that preoperative pembrolizumab is now the standard of care for stage 3 and stage 4 PD-L1 expressing head and neck cancer, but it's in the context of a pretty low major pathologic response rate. And so this idea that you're going to get a much higher response rate with the addition of chemotherapy has been around for a while. And this was a randomized trial of chemo PD-1 inhibition versus immediate surgery with a very striking difference in disease-free survival. And I expect that is going to be something that maybe more the cooperative groups than industry is looking at pursuing, but that we'll see move forward as a very promising approach in head and neck cancer.
I'm curious, and you touched on this a little bit earlier, but We know ADCs are moving into the head and neck squamous histologies.
Yeah, so there
I
was,
think we're all waiting. How far are we from seeing
Yeah.
the ADC?
so we're all pretty excited about CRB-701, which is a novel Nectin-4 ADC with a MMAE payload. It was a very small number of patients, but at the maximal dose in their phase 1 study, they had a 48% response rate to CRB-701. And what's very intriguing about this, in contrast to, let's say, the EGFR or MET ADCs, is that this appears to be active in virally associated cancers. So for our HPV and EBV associated head and neck cancers, where we haven't really had a lot of targeted therapy previously, that looks really promising. We wasn't at ESMO, but the people are pretty intrigued about ABBV 400. SASE has been a little disappointing in head and neck cancer. I think the highest response rate's been about 16%, which is also where the tissue factor ADC landed. And we are waiting for a completed cohort with patritumab deruxtecan. But as I said, I think that that's something that maybe need to be understood in the context of combination therapy. Oh, and HER2, there are a number of HER2 ADCs that have looked extremely promising for HER2 expressing salivary gland cancer.
Really good to hear that perspective. And you didn't tell us when we were going to get the next one, but we'll take the optimism and look forward to seeing that. Dr. LaRusso, your take on post-ESMO, what are you excited about?
Yeah, so, obviously the ADC platform has been real exciting, and, I deal with earlier phase drugs. So there's a lot of interest right now and a lot of great drugs. I mean, the SEZ6s targeting small cell, who would have ever thought that we would be able to get those type of responses second line and beyond? And small cell, although some of the data that's presented is somewhat early, non-randomized trials, but nonetheless, it lends hope. I mean, we're starting to see also epigenetic targets that are making a significant difference in the therapeutic outcome of both myeloma, and that data has been presented previously, but also in breast cancer. We're starting to understand epigenetics to the degree that it's actually now shedding positive outcomes in solid tumors, which was unheard of for years, but albeit primarily in combination strategies as we unfold the biology of the disease. There's a lot of great things. I mean, it's exciting to be in drug development right now because there's so many good things that are coming through. Many, many years ago, we developed a gamma secretase inhibitor, and it was published, and it showed some activity in desmoid tumors, but the outcome was they weren't going after desmoids, and they went on to somewhat develop the drug, but it was pretty negative. And now what we're seeing with next generation gamma secretase inhibitors, we're seeing such therapeutic benefit in a disease that had really no therapeutics. So things like that, I think, are very, very exciting. We see those tumors, some of us that are working in that space see significant positive outcomes with minimal toxicity in a tumor that previously, no one really wanted to go after, in part because it was more rare, but secondly, it really didn't respond, maybe because of the biology and the doubling time, et cetera. But we're starting to see these things, and this is what makes drug discovery both exciting as well as challenging.
Couldn't agree more. I think that's why we're all here and why we're so grateful to get your perspectives on this, especially, from someone who, sees so much of that early development and can give that view into, how the market's evolving. Dr. Schramm, curious, same question for you. Post-ESMO, what are the highlights? I know we've seen, a number of trials in the GYN space. Curious which one stood out to you and what you're looking forward to in the next couple of years.
Yes. So, thankfully, we've made a lot of progress beyond carbotaxol, which was forever what we gave for these cancers. And I think, echoing what others have said, ESMO had a lot of really exciting ADC studies, many of them topo-1 payloads, but, folate receptor targeted ADCs, I think are extremely exciting. We have mirvetuximab as an FDA-approved option, but the tolerability can be challenging. And I think the ESMO presentations by Lilly, by AstraZeneca, really demonstrated that we can improve upon both the efficacy and the tolerability of folate receptor targeted ADCs, which is folate receptor positivity is pretty common in ovarian cancer. It's a high volume disease in terms of, we see a lot of patients. So I think that the exciting advances in folate receptor targeted ADCs, absolutely. And then, of course, there were novel targets. So NaPi2b was a new ADC target that was introduced by the Tubulus group. And I think it was cool to see that a totally novel target was being used and really exciting early results from there. And then, as someone who also does a lot of small molecule inhibitors, not specific to GYN cancer, but I think the zongertinib data, which is a HER2 tyrosine kinase inhibitor, is a good example of how we can improve upon targets that we've had for a long time. And so many of us have run studies of HER2 inhibitors. Often it also targets EGFR, and the therapeutic index has been a problem for many years. And so there have been a lot of companies that have tried to make a HER2 TKI with a good therapeutic index. But I think that the zongertinib data and Nuvalent and others have shown that we actually can improve upon what was challenging for so many years and make a HER2 specific TKI that does not have substantial diarrhea, that does not have substantial skin toxicity. And the lung cancer data that was presented at ESMO in HER2 mutated lung cancer was very impressive, but obviously the target is expressed and mutated in many other diseases. And so I think that opens up the opportunity for just developing better TKIs within known target spaces, if that makes sense.
And, I think she brings out an important point because zongertinib is oral and no ILD, which is, one of the challenges with some of the ADCs that have topo-1 that are targeting HER2, no interstitial lung disease. Toxicity profile is different, and the patient doesn't have to come in for an infusion. Patient can take the drug at home, and there's therapeutic index that is not really narrow. It's somewhat of a wide therapeutic index, which makes it also very encouraging. One of the other things in the GYN landscape, Allie was talking about, or Dr. Schramm, was talking about folate receptor alpha. Mirvetuximab, the initial phase 3 trial that was done, it was negative. And then they went back and had to look specifically at folate receptor alpha high. And it was only in the folate receptor alpha high ovarians that they got the benefit that led to the FDA approval of the drug. We saw ADCs, specifically, as I was talking about before, ZW191, were some of the best responses. Overall response rate, albeit only phase 1, PR plus CR rate in ovarian 64%, but there were great responses in folate receptor alpha negative ovarian cancer. I think, like I said, it's pretty exciting right now.
Yeah, I think we saw a lot there. And
oh yeah,
even, from the angle of the from breast cancer, we saw Cento-3 and Tropion-Breast02 kind of beating chemo in frontline. So we had some questions that folks here are really curious to ask about that. Unfortunately, we are just up on time. We could do this all day, but I do want to thank everyone here so much for taking the time. Hopefully we can do this again. And, really looking forward to kind of how these developments pan out. And I'll hand it over to John to sort of close us out.
Yeah, no, absolutely. Thank you again, Dr. Burtness, Dr. LaRusso, and Dr. Schramm. It's been an excellent discussion. I always love seeing kind of clinicians riffing off each other and kind of thinking about the different aspects as it relates to your own tumors. With that, we'll bid you all adieu. And for those who joined in today, recording will be made available on our site later in the day. All right.
Thank you for inviting me.
Thanks very much. Take care.
Bye, everyone.
Bye, everyone.